Good morning and welcome to the Department of Medicine Grand Rounds. I'm pleased today to introduce Dr. Katsanos, one of our recent recruits, a star in stroke clinical and research work. Dr. Katsanos is a vascular neurologist practicing out of the Hamilton General with a stroke team, and he's an assistant professor at the McMaster University, Department of Medicine, and an investigator with the PHRI. Aris obtained his medical degree from University of Ioannina School of Medicine in Greece, and completed his training in neurology at the University of Ioannina and the National and Kapodistrian University in Athens. He completed his PhD thesis at the Department of Neurology at University of Ioannina as well. Following that, he completed research fellowship in Germany, and afterwards 2 years stroke fellowship in neurology at McMaster University. He has a pretty impressive research portfolio. His research focuses on emerging neurosonology application and the evidence-based evaluation of novel therapeutics in acute stroke treatment and secondary stroke prevention. He has received multiple awards. I will skip listing them, pretty impressive. And at this young age, he has published more than 250 papers and more than 80 abstracts in high-impact medical journals. Dr. Katsanos will talk to us today about is inflammation a new therapeutic target for intracerebral hemorrhage? Without further ado, Aris, please go ahead.
Thank you so much for the super kind introduction, and it's a pleasure and a treat to be with all of you. So first, we need to acknowledge that we are privileged to practice medicine and research in lands that indigenous people have called homes for thousands of years. And I think the presentation is very topical to that, as I'm going to talk about colchicine, which started as a herbal medicine. I have no particular disclosures. I just want to acknowledge that I'm going to present a study that I'm co-leading that is supported by CHR and PHRI grants. So I'm going to start with describing the risk of vascular events after an intracerebral hemorrhage. I'm going to discuss about the inflammation and the risk with atherosclerosis and thromboembolism. I'm going to talk then about the inflammatory response following an acute intracerebral hemorrhage, and I'm going to briefly present some ongoing research on this regard. So first of all, ICH, intracerebral hemorrhage. So although these are under a third of strokes, they account for more than 50% of the global burden of death from stroke. And although we've done a pretty good job in primary and secondary ischemic stroke prevention, we cannot say the same, unfortunately, for intracerebral hemorrhage, as the incidence and the case fatality hasn't decreased substantially since the 1980s. A reason for that is that the management of ICH survivors is pretty challenging. So those patients, they have a high risk for vascular disease. And at the same time, because of the recent bleeding, we have a hard time giving them medications that they prevent vascular disease. This is a study done from US, a population-based study. So what this study tells us is that a person after an intracerebral hemorrhage is at the 3 times higher risk of getting vascular events during their lifetime. And as you can see in the Kaplan-Meier curves, this risk accumulates over time. And you can see that the risk is also for ischemic stroke, but also for myocardial infarction and other cardiovascular events. The interesting point is that this risk starts right after the intracerebral hemorrhage. And it seems, again, from population-based studies, that this risk is particularly increased in the first 6 months after the onset of the ICH, and especially in the first and second months. So we're talking about a very high risk, which is front-loaded. And we have seen this also in randomized clinical trials. So I'll just mention the ANNEXA study, the ANNEXA 4 study, which was a study using andexanet alpha in people that they had a bleeding intracranial or extracranial, and they were on factor 10 inhibitors. So what we did find out in that study is that 10 of the patients had their thrombotic events at 30 days within a month, and the majority of these events happened prior to a thrombotic resumption. And similar data we get also from Sweden. So this is the risk stroke. So it's a big registry, a stroke registry. that suggests that survivors from ICH, only 40% they resume their antiplatelet treatment within a year. And when we're talking about anticoagulation resumption, if they resume it, it's happening after 3 months. And again, we're talking about patients that they have indication to be on antithrombotic or anticoagulation. So as you can see here, the minority of people, they go back to their antithrombotic treatment. And if this happens, it happens in a delayed fashion. Very interesting data are coming from Restart trial. To let everybody know, Restart was a trial that was done in the UK. So patients that they had an intracerebral hemorrhage and they had indication for antithrombotic treatment, they got randomized to either resuming the antithrombotic treatment, the antiplatelet treatment, or not starting it. So in that trial per protocol, they gave the opportunity for investigators to randomize and then start the antiplatelet treatment if they were allocated to this arm as soon as 24 hours post ICH. And although they gave this opportunity for this early recruitment into the trial, you can see here that the median time to randomization, and this is a time that the investigators felt comfortable about resuming antiplatelet if the patients were randomized to this group, was 76 days. So we're talking about a month and a half. So you can see here how reluctant we are to start antithrombotic treatment, and the participating centers were big centers and stroke neurologists, and they were well aware about imaging and also about the risks and benefits of antiplatelet treatment in that setting. So why are we thinking that about that so much? And this is another study again from the UK, which tells us that we are discharging patients, and only the minority of them, you can see here, only 6% after an ICH that they have indication for antithrombotic therapy, they do get it at hospital discharge. The reason for that is that because we have to juggle with the risk of recurrent ICH. And based on this study, it's 3% per 100 patient years. And there is a difference between lobar and non-lobar. If it's a lobar ICH, the risk is higher. If it's non-lobar, it's a bit lower. And at the same time, we're aware that these patients, they're at a lifetime risk of vascular adverse events. So we have to decide what to do. And we're always afraid of the recurrent bleed, but at the same time, we're worried that this patient may have a heart attack or an ischemic stroke down the line. So where's the unmet need? So the unmet need is that the patients with ICH, they're at high risk of thrombotic events with current treatment strategies. And this is aggravated by the imposed cessation of antithrombotic medications for significant periods after the bleed. So we'd really like a novel treatment that modifies the high risk of vascular events, especially in the first days and weeks that we are not able to give antithrombotics. So we just want it all, and we want it now. And I'm going to talk a little bit about inflammation, and you'll see how inflammation comes into play in that setting. So we knew from decades that inflammation has a crucial role in the pathophysiology of atherosclerotic plaque destabilization and thromboembolism. And in fact, it is involved in all stages of atherosclerosis development. So atherosclerotic crystals, they go into the vessel wall and they trigger an inflammatory response. So neutrophil macrophages, they're coming in, they eat those crystals, and they present them as damage-associated molecular patterns that they are able to trigger an immune response to our bodies. It seems from years of research that this inflammasome node-like receptor 3, which is one of the on and off switches of inflammation to our body, seems to be very critical in this pathway between atherosclerosis and inflammation. So this inflammasome, what it does, it mediates the increased expression of interleukin 1 beta and 1 beta and 6 and 18, that leads to an inflammatory cascade. And we know that IL-1 and IL-6, they also can activate acute phase proteins as fibrinogen, plasminogen activator inhibitor 1, and CRP, which in turn they can aggregate atherothrombosis and they can lead to vascular events. So we know that there is association of inflammation and cardiovascular events. We knew that from epidemiologic studies and randomized clinical trials. So we know that studies from patients with heart disease and also stroke, that there is a linear association with CRP and the risk of vascular events. The CRP is higher, the risk of vascular events is higher, and we did find the same associations with IL-8, TNFA, matrix metalloproteinase, and IL-1A. The first study to test this hypothesis, a randomized clinical trial, was Jupiter trial. So it was a randomized clinical trial enrolling healthy individuals without dyslipidemia, that they had increased high sensitivity CRP. So what they did find out is that rosuvastatin not only decreased the LDL and major adverse cardiovascular events, but also decreased the levels of high sensitivity CRP compared to placebo. But the definite evidence that indeed targeting inflammation in patients with atherosclerosis makes a difference came from the CANDOS trial. So CANDOS trial was a trial testing canakinumab, which is a monoclonal antibody inhibiting interleukin-1 beta, and it was given in patients with myocardial infarction, and they were compared to placebo. What they did find out is that canakinumab lowered the risk of major adverse cardiovascular events without affecting LDL cholesterol purely by targeting inflammation in those patients. And in fact, mechanistically, we're able to see that the greatest benefit was seen in the ones that they had the largest reductions in the levels of inflammatory markers. Although the trial was positive, canakinumab didn't reach the market because it was very expensive. And as we all know, patients with heart disease, they're around the globe, and there are many of them. So I don't know if any health system would be able to support such an expensive medication that needs to be so widely implemented. And the second thing is that they did find out that there was an increased risk of infection and sepsis in the patients that they were allocated to receive canakinumab. In stroke, there is a lot of active research going on about inflammation and the stroke risk. So this is a study done by Peter Kelly and his group in Ireland. So they use FDG PET, and you can see here very nicely that there are plaques in the carotids, even that they are non-stenotic, that they are picking up glucose, and that means that they are inflamed and they have active inflammation. And what they did find out is that if this happens, those patients have a very high risk of getting a stroke over the next 5 years. And there is trials going on targeting inflammation in acute ischemic stroke at this point. So it seems that inflammation is everywhere, including the atherosclerosis and all systems. So I'm going to talk a little bit about colchicine, and you'll see where I'm getting to. So colchicine is in fact an ancient drug. So its first documented use was in the papyrus of Ebers. It was in the days of ancient Egypt, and also it was used in ancient Greece, and they used this plant that the extract from the colchicum Haudenosaunee is the known colchicine as ephemeron, which means that it is kind of a poison, that its effect may be delayed for a considerable time interval, and they used it for treatment of joint pains and swelling. In our days, it's a medication that we are using for treatment of gout and Behçet's disease, and also in patients with familiar Mediterranean fever. It is also used as an add-on therapy for pulmonary fibrosis, biliary cirrhosis, vasculitis, pseudogouts, pulmonary arthritis, scleroderma, and systemic amyloidosis. It is a drug that is very well tolerated and safe. You can see here a list of potential side effects. In the low doses, what more patients are getting, and it's 1 to 10 to 1 to 20, is this gastrointestinal effects as abdominal pain, nausea, vomiting, diarrhea, which can manifest, but fortunately they are self-limiting if you decrease the dose or you stop the medication. So colchicine attracted recently a lot of attention because of its potential to have some role in atherosclerosis-related inflammation. In fact, it works in a kind of like a mysterious way that we don't understand exactly. We know that it binds to tubulin heterodimers, and leads to inhibits tubular polymerization. It seems that it has a very broad action by multiple anti-inflammatory effects, inhibits the expression of pro-inflammatory cytokines, modulates oxidative stress, and we know from data that it seems that it downregulates DNLP3 activity, which is a very critical inflammasome in the atherosclerosis-related inflammation, and also in the ICH-related inflammation, as we're going to see in the next couple of slides. So there were many trials testing low-dose colchicine, primarily in patients with coronary artery disease. Two big trials, CoVasc and LODOCO-2, that they were recently published. CoVasc assessed the colchicine 0.5 milligrams once daily in patients with recent myocardial infarction, and LODOCO-2, low-dose colchicine in patients with stable coronary artery disease. Four of them, LODOCO, CoVasc, COPS, and LODOCO-2, they used composite cardiovascular events as their primary outcome. And this is a very nice meta-analysis published in the European Heart Journal, summarizing the evidence from these four clinical trials. And what it shows is that a low-dose colchicine decreases the risk of myocardial infarction by 22%, the risk of stroke by 46%, the risk of coronary vascularization by 33%, and the risk of major adverse cardiovascular events by 25% if given in patients with history of coronary artery disease. Interesting for us practicing stroke neurology is that the reduction in ischemic stroke is profound. As you can see here, is 50% without an increase in the risk of hemorrhagic stroke. Of course, events in those trials, patients with hemorrhagic stroke, they were scarce. We're talking about very low numbers and huge uncertainty. But it's also very thought-provoking at the same time. Another important point raised by this trial is that colchicine is indeed a very safe medication. So these were phase 3 large trials, more than 5,000 individuals each trial. And although in CoVasc there were increased rates in nausea, flatulence, and some suggestion for maybe high rates of pneumonia, which has been consistently shown also in other trials using low-dose colchicine. Reassuringly, in LODOCO-2, the rates of hospitalization for infection or gastrointestinal symptoms were not higher in the patients allocated to the colchicine group, providing reassurance that if these events happen, they are self-limiting and rarely cause trouble for the patient or jeopardize their well-being. And also, very importantly, colchicine is a drug that is widely available and it's inexpensive. So here I'm comparing a little bit apples with oranges to different trials, but I just want to give you kind of an estimate on the numbers. So a year of treatment for colchicine, if given for a patient with coronary artery disease, it costs less than $100, expecting a benefit of 25% in the reduction of major adverse cardiovascular events. And if we're taking the data from the Katsanos trial, we'll have to give 73 grams to every patient with coronary artery disease to get a 15% risk reduction in the risk of major adverse cardiovascular events. And again, I'm comparing two different trials, so take this with a grain of salt. But the point over here is that colchicine is a medication which is out there, and it's also inexpensive and can be used in all settings in low-income countries, low-middle-income, and high-income countries. And very recently, we had approval. So in Canada, we have Health Canada approval of MyInfla, which is an extended release colchicine tablet used for the treatment of patients with coronary artery disease. And very, very recently, a couple of months ago, FDA approved a low-dose colchicine with a very broad indication. They listed as atherosclerosis. And this drug is now available in the States to give it and treat patients. So I'm going to switch gears a little bit, and I'm going to go to the brain. And I know it's early morning, but I'm going to talk about brain hemorrhage and dead neurons. So I hope you have your coffee with you and stick with me. So when intracranial hemorrhage happens, what happens is blood spits from the vessels inside the brain. So you have the immediate effects of increased edema. You have increased intracranial pressure. You have disruption of the blood-brain barrier, and you have what we call the primary brain damage, which is purely mechanistic. So you have all this increased mass effect, which is destroying neurons and leads to brain damage. However, at the same time, the blood spits into places that it shouldn't be there. So that triggers an inflammatory reaction, which comes primarily from heme and iron that they are coming out of dead erythrocytes. And they trigger an inflammatory reaction, which is more delayed, but leads to more neuronal damage. And that's what we call secondary brain injury. So as we discussed already, the blood products, they destroy neurons, but at the same time, they trigger a Th1 response, an immediate inflammatory response to the brain. And we have increased penetration of inflammatory cells into the central nervous system, and also activation of cells that they reside in the central nervous system, release of inflammatory cytokines that they are toxic to the neurons and destroy more neurons. But inflammation is not only bad. So we have, after a while, a Th2 response, and cells are coming into the central nervous system. This is the M2 microglia, and also the cells that they are resident in the central nervous system, that they try to to restore the damage, clean out the dead cells, and promote neural regeneration. So we're talking about hematoma clearance and suppression of the inflammatory disease and tissue regeneration, in a way trying to protect ramified microglia and promote recovery. So all this, we think it's happening, and we have data supporting that in the pre-hematomal zone. So when you do a CAT scan in a patient with endocrinal hemorrhage, you see this hyperdensity, this white stuff that it's the blood, and around the blood you see an area which is hypodensity in the CT, which is what we call pre-hematomal edema. So that's a zone where you get the inflammation. We know it begins right away after the onset of the bleeding. It peaks around 10 days following the ictus, and there is very active research in stroke, as this pre-hematomal edema has been associated with many outcomes in patients after intracerebral hemorrhage, and it's now used as a surrogate marker of secondary brain injury. And in intracerebral hemorrhage, we don't know many things, and one of those things that we don't know is that the importance of DWI lesions we see in the MRIs of patients with intracerebral hemorrhage. So I'll just elaborate a little bit more about it. So a patient has an intracerebral hemorrhage. So as neurologists, we want to understand what's happening. So sometimes what we do, we ask for an MRI to see if the patient has, for example, underlying malignancy or cerebral amyloid angiopathy. So very frequently, and in fact, the prevalence has been reported to be somewhere around 30%. We see DWI restricting lesions in places that they are not even close to the intracerebral hemorrhage. So although we see that in patients that they have an acute ischemic stroke, this DWI restriction, we don't know the importance of these DWI lesions that we see so frequently in patients with acute intracerebral hemorrhage. There are many hypotheses. The primary hypothesis that has been explored and now has been refuted is that they have to do with changes in the blood pressure. There have been many analyses from trials, and it seems that this is not happening. So now the main hypothesis that we're exploring is that these DWI lesions could be the result of inflammatory response of the brain to the intracerebral hemorrhage, and there is a lot of research trying to prove or disprove it. And other things that we don't know, and we think that inflammation may have something to do in our patients after intracerebral hemorrhage, is this progressive cognitive decline we see in follow-up of our patients. So although patients after intracerebral hemorrhage, many of them, they don't have vascular events or another brain bleed, we do see that there is a progressive cognitive decline and a secondary neurodegeneration. We don't know exactly why this is happening. It is an area that hasn't been explored yet. But there is a suggestion that maybe inflammation has something to do with it, and this is something that deserves to be further explored, also for treatment options. So your question is, okay, so what are the evidence that we have that colchicine does something in the brain, penetrates the blood-brain barrier, does something? So really, we don't have really good evidence. So I did a literature research a couple of years ago, and the only thing I was able to find is this study in 1996 from Karolinska Institute, that they used colchicine and other medications in patients, in rats with experimental brain contusion. And what they found is that colchicine was able to reduce brain edema in those rats. And because we were very interested about the use of colchicine in patients with intracerebral hemorrhage, and I'm going to present the trial that we are currently leading, we collaborated with the University of Alberta, and we made collagenase models of the collagenase-induced bleeding model in adult male and female rats. So we used pre-treatment with colchicine in some of the rats, and some others we post-treated with colchicine. We use an allometric scaling dose, which is equal to the low dose of colchicine used in cardiology trials. And we wanted to see what is the response of the bleeding and the hematomal edema in using colchicine. So what we did find out first is that colchicine did not impact hematomal volume. There was research suggesting that colchicine may have an antiplatelet effect and maybe increasing the bleeding risk. Because we're dealing with a very fragile population with recent bleeding, we want to make sure, and this data is reassuring, that colchicine does not seem to have an impact on hematomal volume in rats with a recent intracerebral hemorrhage. And the very thought-provoking and is that the rats that they were taking colchicine 2 hours post-ICH, what we did find out when we dissected their brains is that they had less inflammation, less iron-positive cells in the prehematomal zone at 14 days post-treatment, which is also really interesting and something to be further explored, both in animal models and also in neuroimaging studies. So I'm going to talk a little bit about the ongoing trial that we are currently leading, and I'm going to summarize how all these things that I discussed sum into the rationale of this trial. So the trial is CoVasc-ICH, so it's colchicine for the prevention of vascular events after an acute intracerebral hemorrhage. So it is a randomized, double-blind, placebo-controlled phase 2 pilot trial, which at this point, what it does, it explores the feasibility of conducting a full-scale trial. As I mentioned earlier, it's supported by CHR and PHRI. And it has two hypotheses, and I'm talking about the main trial. We want to explore if anti-inflammatory therapy with colchicine can reduce the risk of major adverse cardiovascular events following an acute intracerebral hemorrhage. And second, if low-dose colchicine given after ICH can attenuate secondary inflammatory brain injury. So consenting participants are randomly assigned 1-to-1 to either oral colchicine or matching placebo, and we're giving it for a median duration of 12 months. And what is the importance of the main phase trial is that if colchicine is proven to be safe and effective, then we'll have a low-cost approach that has the potential to change clinical practice and improve the health outcomes of ICH survivors. So this is the trial outline in a nutshell. So we're including patients with prior intracerebral hemorrhage, which needs to have happened within the last 48 hours, and they should have established or risk factors for atherosclerosis. So we have a pretty broad inclusion and exclusion criteria. So we're including patients that they have either history of previous coronary artery disease, previous ischemic stroke, or they have imaging evidence carotid stenosis or atherosclerosis as found by imaging in any part of their body. But because we know from research that atherosclerosis related inflammation is there in all the stages of plaque development, we're also including patients with vascular risk factors that they are at risk of developing atherosclerosis and developing vascular events. So based on our inclusion and exclusion criteria, and the exclusion criteria is mostly have to do with patients that they are not able to get or tolerate colchicine. We're expecting that more than 80% of patients with primary intracerebral hemorrhage will be eligible for the trial. So at the pilot phase, we want to get 100 patients and half of them to get randomized colchicine 0.5 milligrams once daily, and half of them to receive placebo. So the dosing scheme is one daily, and the plan is for those patients to get the medication to a common termination date. And the common termination date comes to the fact that when we enroll the last participant, the participant number 100, we're gonna follow him for another 6 months, and all the patients will stop at this date. So we're hoping to get recruitment within 24 months and to finish the trial in approximately a year and 2 years and a half. So at the same time, we're also doing an MRI sub-study as part of the trial that I'm going to talk a little bit about it in the next couple of slides. So as I mentioned earlier, we're doing a pilot phase, and we want to see whether we're able to achieve a good recruitment. Unfortunately, most of the ICH trials have been limited by low recruitment. Intracerebral hemorrhage patients, first of all, there are not as many as acute ischemic stroke patients. Second, most of them, they present with really bad deficits, and many of them we withdraw care because of their poor outcomes. And also, there is a difference in the perception of patients of the treatment of patients with intracerebral hemorrhage. Because of the lack of treatment, many physicians have a nihilistic approach that the bleeding has happened. We don't have treatment to offer you as thrombolysis or EVT that you have an acute ischemic stroke, so you're kind of like doomed to have a poor outcome. So for all those reasons, the recruitment rate has been a major issue for trials trying to test therapies in acute intracerebral hemorrhage. So we thought about it, and before embarking into a full-scale study, we want to make sure that we're able to get patients in, and we're able to run a big phase trial. So our target is to get 10 patients per center per year, and we're gonna expand to 11 sites within Canada. And this recruitment rate is not arbitrary. So when we're thinking about the big phase trial, the phase 3 trial, we have made smart calculations, and we think that we'll need around 700 participants throughout the globe. So based on the funding, which is going to be, as you all understand, from public resources, and also based on our stroke trial network, we think that if we get less than 8 or 10 patients per center per year, it will not be feasible for us to proceed to a main phase study. The other thing that we want to see is that patients they are interested into the study rationale, and more than 1 out of 3 they provide consent and enroll into the study. Third most important thing that we need to make sure is that our loss to follow-up is less than 10%, so that patients they don't drop the study and we're not able to follow them. And another important point is drug adherence, and this is very timely for this particular study. We know how drug adherence is for patients with coronary artery disease, for patients after surgery, the recent COP-AF trial led by David Conan. But patients with ICH, they're more fragile. Many of them, they have swallowing problems, and we want really to make sure that we can have a decent adherence of drug that makes us comfortable going into the large phase study. So our expectation is, as I told you, to proceed with the phase series study, and ideally to roll over the patients that we're going to enroll into the pilot phase to the main phase study. That's why we're collecting also major adverse cardiovascular events as our primary efficacy outcomes. And this outcome consists of ischemic undefined stroke, myocardial infarction, revascularization procedures of coronary, carotid, or peripheral arterial disease, resuscitated cardiac arrest, or cardiovascular death. And then we're also exploring some secondary outcomes. And again, these are collected in anticipation to roll over patients into the main phase trial, but also to see the feasibility of collecting those outcomes in the pilot phase. So we're looking at functional improvement during follow-up assessed by the modified ranking scale score. To those of you who are not familiar with MRI score, it's an ordinal scale. 0 means no symptoms at all, 6 means death, and there is scales, so minimal symptoms that prevent you from doing your activities, and so forth and so on. So we are collecting MRI scores during the study follow-up to see if there is any difference in the functional improvement of the patients. Second thing is that we are looking at their cognition, and if you remember in the previous slide, there is this hypothesis that some of the cognitive decline may be explained by active inflammation into the brain after the onset of the ICH. So we're using the telephone version of the MOCA, and because the testing of the executive function cannot be performed, unfortunately, over the phone, we use the mental alternation test. So the mental alternation test is a very simple test to administer. What you do is you ask patients to alternate between numbers and letters. So, for example, 1A, 2B, 3C, and so forth. And the last thing is we want to see what is the impact for good or for worse in patients, in ICH patients getting colchicine. So we're screening for quality of life with the EQ-5D questionnaire. So, of course, a very important aspect of the study is to ensure that the colchicine is safe in this population. We know that it's safe, as I shared the data earlier, in patients with coronary artery disease. We know that it has been safe in patients with COVID, and we know that it has been safe in patients post-op and in the later setting, given for a brief duration of time. But we don't really know that colchicine is safe in patients after intracerebral hemorrhage, because we're talking about a population that is severely impaired with many comorbidities and high risk of complications happening. So only a phase 3 study with adequate power will be able to prove that colchicine is indeed safe in that setting. And that's why we're monitoring for safety outcomes, which includes symptomatic hematoma expansion, rates of gastrointestinal toxicity, rates of infection, which is very critical for patients with acute intracerebral hemorrhage, total hospitalization in days, incidence of a recurrent intracranial bleed, and all-cause mortality. And what's the importance, and outside of the trial setting, is that if we prove that colchicine is safe after an acute ICH, then this provides additional reassurance to treating physicians to continue or introduce colchicine treatment in the state of acute ICH according to current indications, for example, in patients with gout or in patients with acute or stable coronary artery disease per LOTOCO 2 and CoVasc-ICH trials. A little bit about the MRI sub-study. So we're funding also from CHR to do that. So in patients that they consent and they are recruited in the CoVasc-ICH, we give them the opportunity to participate into an MRI sub-study to get an MRI between 7 and 13 days following ICH symptom onset. So what we are exploring in this MRI sub-study is perihematomal edema volume. So going back to my previous slides, is this hypodense zone around the hematoma that we see in the CT brains of patients. And in the MRI, it shows us increased signal in the T2 flare sequences. And what we're doing is we're comparing that perihematomal edema adjusted by the volume of the bleed between patients with randomized colchicine or the ones that they are allocated to receive placebo. And so we're getting a sample of 60 out of the 100 patients to undergo MRI sub-study. And although we'll not have sufficient power, we estimate that if there is a 35% reduction in the perihematomal edema adjusted for the ICH volume, we'll have an 80% power to show statistical significance. That's one point that we want to explore into the brain imaging sub-study. The other thing is that, and going back to my previous slides, to see if colchicine has any impact in these DWI lesions. So what we're going to do, we're going to look at the MRIs, and we're going to see if there is a difference in the DWI lesions that we see in the MRI performed at between 7 and 13 days between patients and participants that they got colchicine and the ones that they were allocated to receive placebo treatment. So currently the study is active. So the first center that was activated was HHS. It was a year ago. It was August 2022. So now we're happy that 9 out of 11 sites, they are up and running. We have 63 participants randomized to date. So we are more than halfway through. We have 2 additional sites to activate, and we are currently seeking for active funding from CHR and other international resources to proceed with the phase 3 trial as soon as possible. So to conclude and summarize the main points, and I'm really looking forward to questions, thoughts, discussion, and feedback. So as you understand from my presentation, there is a need for novel treatments in ICH survivors because those people there are at a very high risk of vascular events, and this risk is very high in the early days following ICH, where we're not giving antithrombotic medications for a very good reason, as you all understand. So targeting inflammation could be a backdoor to resolve this issue, as we're hoping that you can reduce the risk of thromboembolic events and secondary inflammatory brain injury without increasing the bleeding risk. And the CoVasc-ICH, as I presented already, this phase is a pilot Vanguard phase clinical trial, investigated the feasibility of a large-scale trial to test the aforementioned hypothesis. I would like to thank you all for your attention, and looking forward to this discussion.
Dr. Katsanos, thank you very much for this overview and the emerging interest in anti-inflammatory and the roles of colchicine, which is quite fascinating, honestly. If you have a question, please put it in the Q&A section, and we'll read it out. Or if you want to ask your question in person, please, as usual, raise your hand, and I'll keep an eye on that so we can bring you in. All right, Dr. Holbrook, we'll bring you in. Need to do this correctly. All right. Go ahead, Dan.
Yes, thank you, Callan. Thanks for the presentation. So Aristeidis, I don't think you know, we haven't met yet, but I'm internal medicine and clinical pharmacology. So the one thing is, all your presentation was very good. One thing I just want to emphasize from the toxicology point of view, it seems to be a little known fact that colchicine is very, very dangerous in overdose. And it's not going to be common, but it is something that people want to take into consideration. A decent overdose with colchicine can be as few as 15 tablets. So, in some of our patients with mental health issues, that can be a real problem. The other thing that's going to be more relevant that we don't really know enough about are the drug interactions. Colchicine is a 3A4 substrate, which is the cytochrome that's most susceptible to risky drug interactions. So just wanted to warn people that you want somehow, I'm not sure how we're going to improve this in the future. You want to be sure that people are only taking their tablets as prescribed.
No, that's an excellent point, and it's also very timely because I had a patient on colchicine for gout, and he had a stroke, and I prescribed a statin, and I got a message from one of our pharmacies about the potential interaction. So my response to them is that they're going to see it more and more happening because of the recent trials, the CoVasc and LODOCA-2. Although the uptake hasn't been great yet, so I think we'll see more and more patients being prescribed colchicine for the treatment of coronary artery disease. So we're going to see drug combinations in clinical practice, and we're going to hopefully monitor for side effects. Points very well taken. I just want to provide a little bit of more input from clinical trials. So, analysis, post-hoc analysis from LODOCA-2, they suggest that there may be some increase in the liver function test, which is mild. There was an issue, and we had a lot of pushback about it from Health Canada about increase in CK and muscle damage and stuff like that, which hasn't been shown in the clinical trials, and we're talking about 5,000 participants. And so I do agree we have to monitor very closely, and that's what we're doing also in our trials. So we are monitoring for drug adherence, including overdosing too. At the same time, we're monitoring very closely for AEs, SAEs, and also, we are mandating blood work to happen at least yearly for all participants. And if there is CKD happening, we also mandate to happen much more frequent than that.
All right, those are really fantastic points as it becomes more popular in various situations, including coronary artery disease. There's a question from Dr. Levine related to the action of colchicine. It says, is the anti-inflammatory effect only in the blood vessels, since colchicine does not cross the blood-brain barrier very well?
Excellent point. So the honest true answer is that we don't know, right? So as I mentioned earlier, colchicine works in a mysterious way. So we don't know how much penetration there is of colchicine to the blood-brain barrier. And although you may think that it's a big molecule, so it is hard to penetrate into the central nervous system, I can tell you that after a stroke and after a bad stroke, the blood-brain barrier gets so severely disrupted that many things could go in. So if I had to take a guess, I would say that probably it is the result of action into the periphery, but also in the central nervous system.
Thank you for that explanation. I think Dr. Gerstein has a question. Herzl, go ahead.
Yeah, great. Aristeidis, that was wonderful. Really nice review. So, and I got cut off for about a minute, so I hope you didn't answer this already. But a really interesting and additional measure that you could do with colchicine that I think I've not really seen a lot of is related to diabetes. Now, white matter hyperintensities are much more common in people with diabetes. People with diabetes have a lot more strokes than people without diabetes. They got a lot more small vessel disease in the brain. There's evidence of inflammation, yada, yada, yada. Plus, there's evidence that some anti-inflammatory drugs can improve glucose control and things of that nature. Now, it's not obviously your cardiovascular outcome, but it's very easy to include in studies such as yours, a hemoglobin A1C at the beginning and at the end. You're going to have a subset with diabetes, for sure. How many, A1Cs get better? I think that's a low cost additional thing. And I'm happy to discuss that with you down the line, because we may very well find some additional effects of colchicine that are not well described.
Yeah, thank you, Dr. Gerstein. And that's an excellent point, and I do agree. So we do get HbA1c for all of our stroke admissions. So we do screen that for that, and it's based on our clinical practice. I'll just make sure in the CRFs that we are including that the results of that test. If not, as you said,
just do it at the end of the study. Just that. That's all you need, and you could get something interesting. So, but I'm happy to discuss it with you.
And you raise an excellent point. So we think that if colchicine has any effect in the CNS, it should be on cerebral small vessel disease. So small vessel disease, as you nicely mentioned, people with diabetes, they are at high risk of having those white matter changes, these DWI lesions. And of course, they're at risk of macro and microvascular complications.
Right.
So I do agree that we need to look, a bit more closer and to look more specifically in patients with diabetes. And also, one thing I was thinking about is also the classes of medication that we use for diabetes control. And maybe there is, kind of like a synergistic effect. Who knows, right? So, but I totally agree with you. It's a population that deserves further investigation and attention, of course.
Great, thank you.
Great point. Potential collaboration. That's fantastic. There's a question from Dr. Curnow, and if I missed this, he mentions about a recent report on a colchicine post-stroke trial that was negative. I'm not sure if you're aware of that, or I'm sure you are.
Yeah. So thank you so much for this comment, and this is also very timely. So the study that Dr. Curnow is talking about is called CHANCE-3. So it was presented in the WSO, the WC, the World Stroke Conference that happened in Toronto, and that was less than a month ago. So this trial was done in China. I'll just give you the overview just to for everybody to be on the same page. So this trial included, first of all, patients with minor acute ischemic stroke or transient ischemic attack. So no patients with intracerebral hemorrhage. So what they did is that they randomized patients to low dose colchicine. So they started with a loading dose. I think it was 1 milligram for 3 days, and then it was 0.5 for 90 days. So their primary endpoint was the risk of stroke recurrence in the first 3 months. So they randomized around 8,000 participants, and the trial was neutral. So no suggestion of efficacy of colchicine in reducing the risk of stroke. Some important points that deserves further consideration. So first, this trial used low dose colchicine for only 3 months. So and this has been acknowledged by the investigators in their presentation that probably it was a very brief time period to see the effects of colchicine, because as we discussed earlier, inflammation in atherosclerosis is an active process, and to immunomodulate and to see an effect, probably you need more time on that. Second is that this trial is done in patients with ischemic stroke, not hemorrhagic stroke. So I think those results will not have any repercussions to the rationale of our study, and I think the question still remains open. Third point is that the question about the use of colchicine in acute ischemic stroke is still ongoing. So there are 3 other trials being done in patients with acute ischemic stroke that they're using low dose colchicine. These trials, they're using low dose colchicine for years, right? So they are in the same mindset as CoVasc-ICH. So they're using for a median duration of around 2 years. So one of them, which is called CONVINCE, it's led by Peter Kelly in Ireland, primarily done in Europe, and some centers also in Canada are participating. I believe it's Calgary. So they're going to announce the results hopefully next May. So I know the study is over. They're just in the follow-up phase. There is another study called Aristeidis, which is a 2x2 factorial design. Again, low dose colchicine for a prolonged period of time, ischemic stroke, and is led by Pierre Marengo, who is also one of our colleagues at PHRI, and it's also active and ongoing. And there is also one study in Australia, which is called CAST. And I don't know the status of the study. This is the only one that I'm not familiar about the status. But the point is that low dose colchicine in acute ischemic stroke for a brief duration seems that is not helpful. Interestingly enough, no signs of safety concerns, no increased risk of bleeding, and I was happy to see that there was no increased risk of infection, which is very reassuring. But at the same time, there are studies going on to see the longer duration of colchicine, if it has any impact on stroke recurrence and cardiovascular outcomes.
Thank you so much, Aris, for explaining that very well. It's interesting, the design of the study and what the target population and the interpretation of that results, So thank you for bringing a spotlight on it. I don't see any further questions or comments. I actually have a question for you, and I've seen that now we're looking at this branded colchicine, sustained release versus colchicine being really cheap, and I don't know what the cost difference. And do you think there will be on this increased use, hopefully, as we improve that it is effective as an inflammatory for these cardiovascular and stroke situations and bleeds? Would that mean, we have to use the more expensive branded, or are we going to stick with the non-branded, not sustained release colchicine that we use every time?
Yeah, this is an excellent question, which again, I don't know the answer. So the good thing about CoVasc is that we're using one of the extended release colchicine tablets. So, talking purely from the theoretical pharmacological point of view, you're expecting that those people are going to get less GI side effects, and that's the expectation, and that's the rationale for making it extended release. And to be honest with you, we opted to go for it because patients after intracerebral hemorrhage, they're very prone to develop GI side effects and infection. So going into the side of caution, we opted to go for extended release. So I think it would be interesting, again, although our population is very different, to compare the rates of GI side effects that we are seeing and the rates of side effects in general to the ones from other trials that they didn't use extended release. And going back to your point about the drug approval, I was a little bit, puzzled by the FDA approval because they gave the indication for atherosclerosis. So if you look at the labeling of the drug that was approved in the States, it's atherosclerotic disease in general. So I was approached by people and say, like, oh, does this have any impact on your trial, or what do you think about it? So I'm kind of puzzled because they give an indication that we don't have really good evidence about it. And I think that every population is kind of like different. I think, intracerebral hemorrhage is a different population. Patients with peripheral vascular disease it's totally different. And there is a trial going on now led by Noel San at PHRI. So I think we should be cautious, when we are extrapolating evidence and the indications.
That's great. I really appreciate your response to this one, and there's a lot to continue to be learned. Clearly, this is thought-provoking as well as a great review of the current evidence. Dr. Katsanos, thank you very much for your presentation this morning, and I wish everyone a good rest of their day. Thank you.
Thank you, everybody.